Hello, everybody. Good to see you virtually. Welcome to our CAP Project Echo. Glad everyone can make it today. Good to see you. Our topic today will be on ADHD. Let's go ahead and go to the next slide. As you're coming in, go ahead and type into the chat your name, what organization you work for, and the county where you see patients. And then if you could add on there, just like imagine if you didn't have to be at work today, where would you be? So if you didn't have to be at work today, where would you be? And let's go ahead and throw that into the chat. For those of you who don't know me, I'm Joanne Jung. I'm a general pediatrician. I work here at UCSF. I practice clinically in San Francisco, and I would be deep in the redwoods if I didn't have to be here today. So love to hear from everybody else, like how you might spend like a free Wednesday as you are all coming in. Okay. And so let's go ahead and move on to the next slide for a few announcements as people are trickling in and typing this into the chat. So for those of you who can, please keep your cameras on. Feel free to eat as you've got the camera on. We know this is the work hour. This is kind of the virtual brown bag lunch, and we all have to eat, and this is our time. So please have your camera on. Please feel free to eat during this time. We are coming in from all across the state, and cameras on just like helps us see each other, to be a bit of a virtual community, even if we can't be in the same physical room together. So yeah, very much appreciated for those who can do that. We will be recording this meeting, but just the didactic portion. We won't be recording the actual like case discussion that's going to be happening later. So just be aware that the recording, that we will be recording. And as you guys know, ECHO really is really built around case discussion. We all have something to teach. We all have something to learn. And so this is an all teach, all learn model. And we could use another case presenter for June 28th, where our topic will be on SSRIs. So if somebody has a patient with SSRI related questions, that would be great. It doesn't have to be tied up pretty in a bow. It could be a basic question. It could be a simple question. These are really times for all of us to learn from each other, and to gain from each other's wisdom. And we definitely don't have to have it all figured out. So let me know if you are interested in sharing a case for June 28th on SSRIs. And for those who are kind of coming in now, this is an intro. As people are coming in, please type in your name, your county where you practice, and where you would be if you didn't have to be at work today, just as a way of just checking in real fast. The final part of the announcement here is that just as a little incentive, you don't have to pass that MOC Part 2 post-quiz to get MOC Part 2 credit if you share a case as part of the ECHO. So let me know if you're interested in sharing in June on SSRIs. Okay, next slide, please. So we're lucky to have with us today our speaker. I think she's familiar to most of us here. This is Dr. Lauren Schumacher. She's an assistant clinical professor of psychiatry. She helps to organize the CME events for the Child and Adolescent Psychiatry Portal. She's also one of our great consultants who helps to answer the phone calls, like when people call in. She is practicing as a child and adolescent psychiatrist for the Division of Mental Health and Child Development at the UCSF Benioff Children's Hospital, Oakland, and in the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. And she provides clinical care basically on both sides of the bay, both at Benioff Children's Hospital, Oakland, as well as in the psychiatric clinics in San Francisco. She will be sharing with us on ADHD. So with that, I'll turn that over to you.
Thank you so much for that introduction, and thank you all for being here today. I'm excited to share with you on one of my favorite topics, ADHD. We'll go ahead and dive in. So after this talk, I'm really hoping you'll be able to take away the ability to explain the process of diagnosing ADHD, talk about first-line treatments, and describe common side effects and how to manage them. And no one involved in the planning or presentation of this activity had any relevant disclosures. So to start with, I really like to use the AAP 2019 update on managing ADHD, because I think they do a really nice job just summarizing kind of how to approach and what to be thinking about with ADHD in primary care. So kind of their overall recommendations are for 4 to 18-year-olds to be evaluating for ADHD, and kind of what that might look like is some screening questions about how things are going in school and at home, and then more detailed screening if there's concerning answers to that. You want to then, if you're hearing things that sound concerning for possible ADHD, want to ensure DSM-5 criteria is met, using collateral from parents, school, therapist, as well as your observations of the patient and their reports. You want to assess for co-occurring and differential physical and mental health conditions. So think about what might else be causing the attention issues, and also looking to see if there's other physical or mental health issues involved. Want to approach treating ADHD like a chronic health condition. And then in terms of treatment for the preschool 4 to 5-year-olds, you think about first-line behavioral therapy, second-line methylphenidate, the elementary school 6 all the way to the 18-year-old teenagers. First line is FDA-approved medication, behavioral treatments, and educational interventions. We want to be trying to optimize the benefit of the medication while minimizing side effects. And then for PCPs, if they're experienced in dealing with the comorbid conditions, can also address those as well. So that's kind of our overarching plan and approach to ADHD. And now we're going to dive into some more details. So first, in thinking about the diagnosis, we want to be looking for at least 6 of either the inattentive or hyperactive impulsive symptoms, and want to see that those have been present before age 12 and for at least 6 months, and that several of those symptoms are present in more than one setting, and they're impairing functioning and not better explained by something else. So for this, the rating scales really become key, because with kind of 18 questions to go through, it's hard to just remember it all off the top of your head. So really using some of those ADHD rating scales can be helpful to make sure you're kind of going through those 18 symptoms. These are some that are available free. There's the Vanderbilt scale, as well as the SNAP. Both of these have parent and teacher options. And then for 13 and older, you can use the adult ADHD self-report scale for a self-report. And some things to keep in mind is, we're looking for both that there's symptoms at home as well as at school or in other activities. And you want to also be thinking about if there's kind of other comorbidities or other explanations for what might be going on. So with ADHD, comorbidity is really the rule rather than the exception, with about 66% of kids with ADHD also having a comorbid psychiatric condition. Any of these we can see, but some of the more common ones that come up are things like anxiety, speech and language challenges, learning disorders, tics, are all frequently come up. And here we have attached to the circles some of the different rating scales and screeners that can be used to look for if some of these comorbidities are in play. Another very common one, the sleep disorder, is always important to ask about sleep. And then with this situation, thinking back to the kind of the last of those AAP recommendations, to also be kind of assessing and managing these conditions along with the ADHD if comfortable, or considering consultation or referral if needed. And this is definitely a great situation where it's great to call CAP, because that's something we're happy to help think through as well. Then in terms of treatment, there's kind of four main buckets of treatment. First, the psychoeducation, teaching the kid and the family about the disorder. Behavioral therapies, which are first line for the 4 to 5-year-olds and for use along with medication for the 6 to 18-year-olds. School accommodations interventions, and then pharmacotherapy, first line for the 6 to 18-year-olds. And so we'll delve into each of these. So in terms of psychoeducation, we have a number of resources on our website, which I definitely encourage you guys to check out and also share with your families. There's some very helpful books, like Taking Charge of ADHD is a guide for parents that talks a lot about the disorder and different strategies for managing it. In terms of the medication piece, ACAP, the Child Psychiatry Organization, has an ADHD parents medication guide that's available online. It goes through the different kind of types of medication, and kind of the most useful part, I think, is it talks through kind of common questions parents have about medication and addresses them. And then Attitude Magazine and chad.org are another helpful places for parents to learn more about ADHD. In terms of behavioral therapy, kind of the behavioral therapy that has the most evidence for being helpful for kids with ADHD is parent management training, which really works on helping parents use behavioral strategies to help support their kids with ADHD. And while, you know, that can be it can be very challenging to link families with kind of formal parent management training, there are a number of kind of principles from it that can be helpful and can be shared with patients even in a relatively short visit. So one I think that is especially helpful to encourage families to do is attending quality time. And this kind of gets at the idea that often kids and families with ADHD have a pretty negative reaction and interaction cycle going, where, you know, the kid is impulsive or does things that kind of elicit negative responses from people around them. And so then, you know, the kid does something impulsively, the parent yells at them, then the kid may be more likely to act out further because they have this kind of negative interactions. So the idea with kind of attending quality time is this is, you know, regular time that's one-on-one between the parent and child, that's child directed. So the kid is, it's a child directed activity, but the parent's fully present. Their cell phone is not next to them. They're kind of observing what the kid is doing and not making judgments and not telling the kid what to do. And this really can go a long way towards making more positive interactions and kind of improving that connection between child and parent. Other things that can be helpful is kind of encouraging having a clear structure and routine, and also encouraging use of rewards to help with challenging behaviors. So that might be something like having a morning challenge where the kid has a short list of things they need to do, and then they're able to earn a reward for that. Then in terms of school accommodations, generally recommend that kids with ADHD have accommodations either with an IEP or 504 plan. ADHD qualifies for other health impairment on the IEP. And these can be things like having a preferred seating arrangement that kind of helps them maybe at the front of classroom where they're better able to pay attention, testing accommodations such as additional time on tests, behavior plans, strategies for kind of teachers if they notice the kid that is getting distracted to kind of help bring them back. And on our website, we have more information too about school accommodations and supporting families in requesting an IEP or 504 plan. And then in terms of the medications, there's kind of four main groups of medications that are FDA approved for treatment of ADHD. There's the 2 stimulant groups, the methylphenidates and amphetamines. There's the alpha-2 agonists, guanfacine and clonidine. Interestingly, there's also separate FDA approval for use of alpha agonists in combination with stimulants. And then there's the norepinephrine reuptake inhibitors, which includes atomoxetine and then more recently, viloxazine. With stimulants, they are very effective with an effect size of about 1 and a response rate of kind of over 70% to an initial trial of a stimulant and over 80% with a trial of an additional stimulant. Some of the common side effects include, as I'm sure you guys have all experienced, decreased appetite, sometimes weight loss, sleep disturbance, potentially stomach ache and headache. Less commonly, you might see things like behavioral rebound. We often see small increases in blood pressure and heart rate, but occasionally you can see more significant hypertension or tachycardia. And then very rarely, things like hallucination, psychosis, peripheral vasculopathy, or compulsive skin picking. Some things that can help with managing some of those common side effects are with the decreased appetite, encouraging substantial protein-rich breakfast before taking medication and dinner when the medication is worn off, because often we see that decrease in appetite affects lunchtime the most. There's also evidence that in kids with taking stimulants where growth is a concern, that having drug holidays on weekends and summers or calorie supplementation with something like Boost can be helpful. If they're having stomach aches, always encouraging them to make sure to eat something before taking the medication. And then if there's issues with sleep disturbance, first, I always make sure to have a sense of what their baseline sleep is like before taking a stimulant, because often kids with ADHD have kind of underlying sleep issues that are not always related to the medication. But if it is a new sleep problem since starting the stimulant, I always want to find out when they're taking the medication and encourage them to try to take it earlier in the day. If they're taking a long-acting one, consider switching to either a medium or shorter-acting formulation. Can consider adding melatonin or an alpha-2 agonist, which kind of provide some additional ADHD symptom treatment and also can sometimes help with the sleep at night, or could consider stopping the stimulant and switching to an alpha-2 agonist or Atomoxetine. And then with if there's issues with rebound, where kind of we expect as the medication is wearing off in the afternoon that the ADHD symptoms return. With rebound, the idea is that they're kind of returning even worse than before. And with that, sometimes switching to a longer acting agent can be helpful, or adding an afternoon booster dose. And then in terms of thinking about choosing a stimulant, you want to think about the mode of administration. So first, like, are they able to swallow pills? Do they need a chewable or liquid? There's a lot of different types. Think about the duration of action. Is it something, is this a young kid where we're wanting to use a short acting? Is this a high schooler who has a full day of school, then a couple hours of activities, then are doing homework and really needs a long acting one? Currently, there's really not good evidence that pharmacokinetic testing is helpful clinically for this. But those are all things to keep in mind. And then I really like the ADHDmedicationguide.com as a free resource. And you can see it here that shows images of all the medications as well as their dosing. So that's something I find helpful to reference for myself. And also sometimes families find it helpful to look at as well. I'm going to skip this monitoring slide for time, but wanted to include it for your guys' reference. This just talks, but I'd say the biggest takeaway is that more frequent visits are associated with more effective medication treatment. So it's helpful to check in frequently, especially when first starting the medication. Then with the alpha agonists, we have guanfacine and clonidine. They are effective for reducing ADHD symptoms, both inattentive and hyperactive, but have a smaller effect size than stimulants with effect size of about 0.6. The most common side effects are the listed as somnolence, fatigue, and sedation, so they can make people tired. If this is an issue, it can be helpful to have them take it at nighttime. Also, we always want to kind of keep an eye out for possible hypotension or dizziness. And a nice thing about the alpha agonist is there's no significant changes in body weight. So this is a good option to think about in the kids where there's either kind of baseline concerns about weight and eating, or who have had issues with those appetite suppression side effects with stimulants. And in addition to, so dosing at bedtime helps with the fatigue. If there's worries about kind of dizziness or hypotension, making sure they're staying well hydrated, sitting up slowly, and monitoring blood pressure. And then we'll go into the SNRIs or the NRIs. So first we have Atomoxetine, which brand name Strattera. This one is similar to alpha agonist, has an effect size of 0.6. It's generally well tolerated, but most commonly we see a lot of GI symptoms. So decreased appetite, GI symptoms, weight loss. One thing that can help with this is starting at a lower dose and also starting with having the dose split BID dosing, and then kind of gradually getting to the full dose and gradually consolidating to once a day dosing. And then the last one is the newest one, Viloxazine, is also an NRI. It was FDA approved in April of 2021, so it's pretty new. Similar to the other non-stimulants, has an effect size of around 0.6. And I think where I kind of think about this one is while the atomoxetine has to be swallowed whole, viloxazine can be opened and sprinkled. So it's an especially good option if you have a kid where you would like to use atomoxetine, but they're not able to swallow pills. And both atomoxetine and viloxazine have the black box warning of possible increase in suicidal thoughts, but you know, it wasn't to the level that it significantly differed from placebo. So then just to summarize here, we think about with all our kids encouraging kind of health behaviors, activity, nutrition, sleep. And then, you know, first line for the under 6 and also for, you know, the older 6 want to think about behavioral therapy, interventions, school accommodations. And then for the over 6, first line or second line under 6 stimulant medication. You want to optimize the dose of that. And then if either there's issues with side effects or only no or partial response, switch to the other class of stimulants. Optimize that dose. If still issues with side effects or no partial response, then think about switching to an non-stimulant, either the norepinephrine reuptake inhibitors or an alpha agonist. If only a limited response with one of those, think about switching to the other. And then at that point, you really want to be kind of also checking in on the differential diagnosis. Are there other things going on that's kind of interfering with their response to treatment? And can think about other options, non-FDA approved options at that point, like bupropion. And then for sleep problems, thinking about sleep hygiene, melatonin, and alpha agonists. All right, those are the references. So
thank you so much.
Yeah.
Thank you so much, Lauren. We got a couple of questions that came through, one that hasn't been addressed yet. Long-term studies on the effects of using stimulants, or for outcomes or for side effects, long-term growth trajectory. What can we share about that?
Yeah, that's a great question. So in terms of the long-term studies, I think the longest randomized control trials we have are kind of up to about 14 months, which is not that long in terms of patient treatment, but is quite long in terms of a randomized control trial. And, you know, at that point, they continue to be well tolerated and continue to help with ADHD symptoms. And kind of for data longer than that, we don't have randomized control trials, but what we have are kind of naturalistic follow-up. So the MTA study, which was one of the ones that did this 14 months of randomized treatment with stimulants versus behavioral therapy versus community care, has continued following these kids, and they're now in their 20s. And I think two pieces I'll bring up with the natural. They broke them up into kind of naturalistic groups of those who had significant stimulant treatment versus kind of medium amount of stimulant treatment versus negligible. So there's ones that kind of had so far had a like significant lifetime stimulant dose, kind of a lower amount, and then they also have a community control group. So these are kids from the same classes as them that didn't have ADHD. And a couple takeaways from that is one, in terms of kind of the overall ADHD group continues to have poorer functioning compared to the local normative controls. So they have more challenges with school, more challenges with kind of general life functioning compared to those without ADHD. Interestingly, in the non-randomized groups, there doesn't seem to be a difference in terms of whether they're taking medication or not in terms of their functioning at that point. And then in terms of side effects, kind of the biggest one we think about long-term is kind of the height and weight piece. And we do see that those who have kind of had a higher lifetime dose of stimulants tend to be on average, I think it's about 2 centimeters shorter than those who kind of really never took stimulants. And in terms of weight, the pattern changes over time. So initially they tend to be lower weight, but then by kind of late teens, 20s, they actually weigh more than the group that didn't take stimulants.
And along those lines, do any nutritional supplements help? Or, but also like for on the integrative side, like for those who don't want to be on medication per se, any idea of like some of the integrative or nutritional approaches?
Yeah, so in terms of briefly in terms of the nutrition piece, and it was a relatively recent randomized trial that looked at different interventions to help with when there was growth concerns in kids with ADHD, and they looked at kind of monitoring versus the drug holidays versus a kind of nutrition supplement like Boost. And they did see that both the nutrition supplement and the drug holidays kind of helped with increases in weight gain. They didn't see kind of any changes with the height trajectory during that study. And then in terms of kind of complementary medicine, there's some data that fish oil can potentially be helpful for ADHD. So that's something, if that's something the family is interested in, I think it's, there's low concerns for harm and it could potentially be helpful. So definitely worth trying. The one thing I'm careful about with the supplements is sometimes there can be a high pill burden with those. So if it's, a case where the kid's taking a bunch of pills and so then they're like not wanting to take a stimulant medication because they're already taking a bunch of other supplement pills, then I think that the stimulant's can be more helpful than the supplement. But if that's not an issue, then I think it's a good option to think about too.
Questions pouring in. When do you want an EKG with medication start?
Yeah, so it's not something that's recommended for all kids with before starting stimulants, but it really think about it when there's a concerning personal or family history. So if there's anyone in the family who's had issues with kind of a heart arrhythmia or any kind of sudden death in the family, those would be kind of red flags that would make me want to get an EKG before starting. And then with the kid, if there's been any kind of like unexplained syncope, things like that, or kind of personal history of cardiac concerns, those would be reasons to get an EKG.
Okay, I'm realizing that some of these are starting to get like typed in. Okay, so there were some questions I want to point out on comorbidities, like comorbid mood or anxiety disorder with ADHD. And I see that Dr. Waring put in some ideas here, but if you want to comment out loud about if there's combined mood or anxiety disorder with ADHD, is there a good first choice medication and what might you choose?
Yeah, so I would say kind of as Dr. Wing was saying, I often try to get at, which is causing one, trying to kind of clarify, making sure they're both present, because certainly depression itself can cause attention issues. That's one of the SIGI caps we think about, concentration. So, carefully thinking through that diagnosis, and if they both seem to be present, getting a sense of which is causing more problems right now. And if the depression is causing more problems, then treat that first and then tackle kind of what the what's left in terms of the attention issues once that's addressed. If the ADHD seems to be more problematic, tackling that first. If they seem equally problematic, we tend to, I think it's a conversation with the family about which to target first, but often we'll think about ADHD first just because the stimulant medications act so much faster than the SSRIs. So that can kind of be started and titrated pretty quickly. And then we can start thinking about SSRI treatment.
And I just want to add in response to one of the questions that came in, that the CBT is great to add in too. Like, no problem with doing stimulants and CBT at the same time if there's that comorbidity.
Yes,
Um,
definitely.
yeah, there's a lot that's happening in the chat here. We'll send out the chat and the Medi-Cal guest formulary that got shared here, because I think that's a great resource. We don't have time to get to all of these, unfortunately, because we need to like turn over to the case. Maybe the last thing, I think we heard a little bit about this, is like, do you routinely recommend drug holidays in the absence of like weight concerns? What are your thoughts on drug holidays?
Yeah, that's a great question, and one that comes up a lot. I don't. If we think kind of back to the diagnosis of ADHD, it's by definition something that affects multiple domains. So it's not something that is only impairing school functioning. It also is often affecting, functioning at home, in social interactions with friends, kind of how they're focusing on the soccer field during their game on the weekend. So if there aren't kind of specific side effect concerns, I do encourage them to take it every day, since it, can be helpful with things outside of school as well. That being said, I think it ends up being a really kind of patient and family specific decision. And I have, certainly have patients where they find it helpful to take all the time. And I have others who are like, it really helps with school, but like, the appetite suppression's okay, but I don't love it. And it's really nice to, on the weekends, just not have to take it. And I think that's very reasonable too. So
Absolutely.
you can really kind of customize it to your patient.
Absolutely. Thank you so much for that. We're going to have to make the switch over. For the black box warning, we are having a separate talk on SSRIs. We'll be talking about the black box warning then. So stay tuned for our echo in June to be hearing more about this. Okay, so we are moving on to the case discussion. And this month we have Drs. Nidhi Doshi and Maggie Gilbreth from Zuckerberg San Francisco Journal sharing their case with us. So I'll go ahead and turn the floor over to you. And this is a great time to come on camera, everyone, so that it's like the brown bag lunch. We're all here and we're talking to each other, even though we are on far sides of the state. Thanks.